Hi, I'm Fumi.
And I'm Nicole, and today we're here with Rotate Ready. Both Fumi and I are clinical pharmacists that work in adult primary care family medicine. And today we're going to be talking to you about the acute asthma exacerbation in the office. So at what point do we add ipratropium? At what point do we add a steroid?
So when it comes to asthma exacerbation, the best strategy is really early recognition and early intervention. And so it's very important that we counsel patients to let them know what the signs and symptoms of an exacerbation may feel like, so that they know whether to call you or go straight to the emergency department. And the decision for that really is based on how severe their symptoms are. So when it comes to moderate severity, patients may have dyspnea that interferes with their usual activity. Their peak expiratory flow may be, or their FEV1 may be less than, between 40 and 69% of their predicted or personal best. And at that time, you can make the decision to either manage the patients in your office, or if they seem to be a bit more severe, then you could triage them to the emergency department. And usually patients can go straight there if they have severe exacerbation. To make that determination, the criteria for that are they may be breathless at rest, they may be drowsy, confused, or agitated, they may be unable to speak in full sentences, their respiratory rate may be greater than 30 breaths per minute, their heart rate may be greater than 120 beats per minute, their peak expiratory flow may be less than 50 of their personal best or predicted, or they may not even be able to actually perform a peak expiratory flow, and their O2 sats may be less than 90%. And then you would know that this is severe and they really should go to the emergency department.
Yeah, and whether we're going to the office or the emergency department, either way, our short-acting beta agonist, so our albuterol, is our cornerstone of therapy. We need to get that started as soon as possible. And the other two things that we start pretty quickly are the oral glucocorticoid and then supplemental oxygen if needed, and keeping that oxygen between 93 to 95%. So for all patients presenting with an exacerbation, we would start albuterol with 4 puffs of your metered dose inhaler every 20 minutes for the first hour. Now, if they are, if they're not improving or feeling benefit, or it's a severe exacerbation, we could even do 6 puffs every 20 minutes for the first hour. If the office has a nebulizer, we can do the SABA nebulized. And that dose is 2.5 milligrams in 3 milliliters, again, nebulized every 20 minutes for the first hour. Interestingly enough, an inhaler with a spacer valve or chamber, or spacer, oh my gosh, chamber or a spacer. Is equivalent to a nebulizer. I always thought the nebulizer worked better, but there's actually evidence that shows proper technique with the inhaler.
That's important.
It's very important. So we often see that patients are not using their inhaler properly. So if they're used properly, they are equivalent. Now, to talk about when to add ipratropium, we would only add this to a SABA in severe exacerbations before hospitalization. So there's actually evidence that shows that ipratropium does not really offer any benefit once you've been hospitalized. So this little niche time is when you're in the office for a severe exacerbation. The dose is 0.5 milligrams every 25 minutes, every 20 minutes for the first hour. And that can actually be mixed in the same nebulizer as the albuterol, which is really helpful because you can administer them together. So you're not staggering their nebs. So it's just every 20 minutes, they're getting a neb with both of them in it. Now, as far as glucocorticoids go, almost every patient is going to get an oral glucocorticoid because the criteria is for less than 80% of their predicted or personal best, which is really going to be anyone with an exacerbation. So we want to make sure it's a short course that is equivalent to prednisone 40 to 60 milligrams for 5 to 7 days. And this significantly reduces the likelihood of any repeat severe exacerbations in the following 2 weeks. An important patient counseling point is once we start that glucocorticoid, patients may feel I should feel better immediately. But if they've had a moderate exacerbation, it can take 1 to 2 days after steroid treatment to start really seeing those symptoms. symptom resolvement. And if it's a severe exacerbation, it can be even 3 days after treatment has started. So patients who improve in our office-based treatment, so their vitals have returned back to normal, they're able to, their symptoms have decreased, they can actually be managed at home. So we can make sure that their maintenance inhalers are optimized and that they have an asthma action plan ready to go, but we can send those patients home. For patients who develop worsening symptoms or they're not getting any better with the SABA, glucocorticoid, or ipratropium, that's when we would need to transfer them to the ED. And the important thing to note here is when we're waiting on the transfer, we should continue SABA and oxygen administration. So these were just some tidbits on asthma exacerbations in the office.
Yeah.
We hope they were helpful.
Yeah, we hope they were helpful to you. And as always, we try to make sure that these are bite-sized information that you could just take back to your practice or even use in your exams. Yeah, we wish you the best of luck, and just remember that you got this. You can do it.
You can do it. Thank
Take
you.
care.